مساء الخير زملائي وأصدقائي في كل مكان، وأهلا بكم النهاردة. الليلة دي هيكون في السكند ويبينار اوف اوبسي كلينكس. وفي المناسبة دي الأول طبعا أحب أشكر جدا التيم وورك بتاع شركة إيفا فارم، الدكتور محمد حسن والدكتور عادل عزيز والدكتور أندرو، على دعمهم القوي جدا لويبينارز بتاعة الأوكيولوبلاستيك سوسايتي اوف ايجيبت. الحقيقة احنا اخترنا من الويبينار ده موضوع التوزس، special situations in ptosis surgery. والحقيقة دايما كان في مقولة بتقال إن without ptosis there is no oculoplastic surgery. وده إن دل على شيء هيدل على أهمية الموضوع ده للتخصص ككل. أحب أرحب وأقدم إخواتي وزملائي في قسم طب العيون جامعة اسكندرية، فرسان الأوكيولوبلاستكس، الأستاذ الدكتور هشام علي إبراهيم، وهيكلمنا النهاردة إن شاء الله على موضوع the use of the levator muscle and frontalis muscle in ptosis surgery. والأستاذ الدكتور إبراهيم يحيى علام هيكلمنا عن decision making in severe ptosis. ومعانا كمان الفارس الثالث أخي وصديقي العزيز الدكتور إيهاب محمد عثمان، أستاذ مساعد طب وجراحة العين في جامعة اسكندرية، وهيكلمنا على management of Marcus Gunn's phenomenon. My talk by myself today will be about the blepharophimosis Epicanthus Inverses syndrome, أو simply we can call it Cohn-Romano syndrome. الحقيقة السيندروم ده relatively common، احنا بنقابله كتير في حالات التوزس. And this was described firstly by Vini in the 19th century, but Cohn and Romano described the full distinctive changes that are present in this syndrome in 1971 in a paper published in the American Journal of Ophthalmology. We have different abnormalities in this syndrome. First of all, blepharophimosis. And by blepharophimosis, we mean decrease in the horizontal palpebral fissure, which may reach up to 18 to 22 millimeter compared to a normal dimensions of 25 to 30 millimeter. The second is ptosis, and ptosis is usually severe, bilateral, and with poor levator function. Despite this, the patient can manage to see through this very small, narrow opening by adopting a chin-up position. A third change is Epicanthus Inverses, and we mean by Epicanthus Inverses this fold of skin originating from the lower lid and obstructing the medial canthus going into the upper lid. And the fourth change is telecanthus. And by telecanthus means widening of the intercanthal distance. Normally, the intercanthal distance should be about half the interpupillar distance. If it is wider, and according to the degree, this is called telecanthus. It may be either primary telecanthus or secondary to a bony abnormality, which we call hypertelorism. Other findings may be seen in this syndrome, like increased brow width with arching, and this is usually a common look of these patients due to recruitment of the frontalis muscle to compensate for the ptosis and the visual field defects. Other findings also, we may get a lateral displacement of the lower punctum and downward concavity of the lower eyelid, like ectropion due to deficiency of the anterior lamella in the lower eyelid. Also, others may be abnormalities in the extraocular muscles, like exo or esotropia, limitation of up or down gaze. Inside the eye, we may get optic disc phlebomata and other facial or maxillofacial abnormalities. We may get high arched palate, like this patient on the right side, a low set cup shaped ears with overhanging helix, but usually the mental status is normal. You will see this picture a lot in this disease. A father with his kids coming with the same look, the same broad brows, and the same narrow eyes and ptosis. And this points to the genetic type of inheritance of this disease. It is usually autosomal dominant. However, we can get sporadic cases which are related to the fetal alcohol syndrome, maybe in 1/3 of these cases. And we have two types of inheritance. Type 1, which has a complete penetrance through the male line, and it is characterized by female infertility as premature ovarian failure. And the second type, it is transmitted through both sexes with incomplete penetrance, and it is not associated with female infertility. And both are involved or involving the FOXL2 gene, which is located on the long arm of the 3rd chromosome. Now, when we meet a case of blepharophimosis syndrome, we have to make our management plan. And as a matter of fact, we have to consult other specialties like pediatric endocrinologists, like pediatricians, maxillofacial surgeons, because as we know, we have to consult also for genetic consultation due to the possibility of premature ovarian failure in females getting this disease. We have to explain to the parents that the correction is complex, and we have to go through different stages to correct these problems. Regarding the timing, the preschool age is a good age to start with, and the anatomy is larger and easier to work with. We usually address the epicanthus and the telecanthus as a primary procedure, followed by ptosis. Though other investigators show that we can do both problems at the same sitting. Finally, we can correct if there is any ectropion or lateral canthoplasty. Our approach is to correct first the epicanthus and telecanthus is to elongate the horizontal shortening of the eyelid and eliminate the epicanthus and the telecanthus. How we get the principle of this is to break the line of relative tightness, which is horizontal, and we make use the excess of tissue that is present in this horizontal line of foot. However, we should know that this correction the traction on the lid may exacerbate the ptosis as a primary procedure. We have to warn the patient about this problem. There are many approaches to correct the epicanthus and telecanthus and blepharophimosis, like Y to V, we call it the Rovida procedure, where, as you can see on the right-hand side, the sketch here, we make a V and a Y, and then we approach this point, the B point, to A points. And in this way, we can shorten the medial canthal tendon and elongate the palpebral fissure horizontally. However, a disadvantage of this technique that the remainder of the flap, this is the area that we can increase in the size, but the other part of the flap is less advanced. Sometimes it can cause a concave scar, like a bridal scar that can lead to a secondary fold. Cohn and Romano described during their description of the case in 1971 what they call C to U plasty. And C to U, we remove the tissues here in the form of C, and then we advance all these two parts to get like a U, or sometimes a single line to advance the medial canthal nasally and elongate the palpebral fissure. As you can see, we make C here, and this part is measured according to the amount that we need to increase the palpebral fissure according to the intercanthal distance. So if we have an intercanthal distance, for example, 40 millimeter with 56 millimeter, say, interpupillar distance, this means that we have to shorten this distance by 12 millimeter, which is divided into both sides, each one by 6 millimeter. And then removing the tissues until we reach the medial canthal tendon, and then either plication and suturing it to the periosteum here, or by doing transnasal wiring and then closure. And in this way, we can, as you can see in the bottom right picture, we can elongate the palpebral fissure. Once again, in more details, the technique, we make our 2C plasties here. Again, here we are drawing the line for the ptosis at the same time. And then we remove the tissues here until we reach the orbicularis muscle, until we reach the medial canthal tendon is present here, you can see it. And undergirding like this instrument, we can separate the medial canthal tendon from its attachments nasally. Of course, you have to take care of the lacrimal system because it is more or less adherent at this point. And then we make an incision in the periosteum to just anterior to the anterior lacrimal crest to expose the lacrimal sac fossa. And then, okay, this is the other side, the right side, the same technique. And then by a bone cutting forceps, we make a small osteotomy on both sides. And we use different types of sutures. Here I'm using a 4O supramid suture. We can use Gore-Tex suture if you want. And then we take a stitch here on the right side through the stump of the medial canthal tendon on one side. And then after passing the right needle through the nasal septum here to get through the other side, of course, we have to put a guard like a malleable retractor here to protect the globe of the other side. And then we feed the eye of the right needle with the free end of the stitch, and then we pull it to the other side, to the first side, and then take the sutures in the other stump of the medial canthal tendon. This is how we do the transnasal wiring. And then we tighten both sides and we close subcutaneous and the skin. We can at the same time do the ptosis surgery. Here I did a Levator resection. However, because of the severe ptosis, you can use a Frontalis sling. Dr. Ibrahim Allam, inshallah, will show us how to make the Frontalis sling in cases of severe ptosis like blepharophimosis syndrome in East Lobe. Another important technique to correct the epicanthus is what we call the Mustardé technique. Jacques Mustardé described a double Z plasty superimposed on a Y2V plasty. And the good thing in this technique is that it permits advancement of the canthi medially while leaving the scar line running through the new canthal site. And in this case, we don't discard any excess tissues. However, the disadvantage of this technique is that there is a considerable suture material in a very small region at the inner canthus. So again, we measure the intercanthal distance and the interpupillar distance. And the excess, we know that the norm is half of the distance. More than half, this distance is divided into both eyes, and we draw the Mustardé double Z plus T, as you can see on the right side. We make a line, I'm pointing to it, from the inner canthus along the distance that we have to advance. And then we divide this distance into halves, and each half make the other limbs, as you can see here, 60 degrees temporally, and then backwards, the same distance, 45 degrees nasally, together with the Y plus T on the side of the lid. Again, we can, in a very short video clips, I will show you how to make this incisions. So here, after drawing it and injecting xylocaine with epinephrine, we make our incisions with a 15 blades. Okay, and then using our scissors to dissect the flaps. After reaching the medial canthal tendon, we shouldn't forget to put our lacrimal probes so that we can point to the canaliculi, so they can be injured during our dissection. So we insert 2 probes in the upper and the lower canaliculus. Here, the scissors points to the medial canthal tendon before cutting it. As you can see here, I'm taking a bite in the stump of the medial canthal tendon. I'm running the video just to show you the important steps. Okay, so we are taking in the stump of the medial canthal tendon. Then we make our transnasal wiring using this instrument. We call it the right needle, a large curved needle with a big eye here. And then under protection with a malleable retractor. Of course, after doing the small osteotomy, you can see I'm using this is the right needle and a sucker tip here, and slowly inserting it through the nasal septum. It needs some manipulation until we get it from, you can see here the malleable retractor on the other side, this one. Next step is that we tighten the both ends, attach it to both ends of the medial canthal tendon, so that we can lengthen the horizontal palpebral fissure. And finally, we take our sutures by 6-0 or 7-0 vicryl through the apex of the double Z first. Can you see on the right-hand side? When we tighten it, we will get this angle nasally, so that you can see now that, as I'm pointing with the pointer here, the medial, the horizontal palpebral fissure is elongated in this way. And then we switch the double Z, and we close by 7O vicryl, as you can see here. So this on the left-hand side preoperatively, this patient with blepharophimosis syndrome, and on the right side, just after maybe 2 weeks of surgery and removal of the stitches. You can see now that the horizontal palpebral fissure is elongated. Despite that, because of this tightness, the ptosis is increased a bit. Another case, in the upper side here, before preoperatively. On the left-hand side, the bottom, after doing the double Z mustardoplasty, and finally, after raising both lids together. These are old cases where we used to do the C2U plasty after doing the ptosis surgery. On the bottom, this patient had also esotropia, and on the right side, after correcting the esotropia and the telecanthus. Thank you so much for your attention, and I will stop here, and I will give the talk to my dear friend, Professor Hisham, on the use of the levator and the frontalis muscle in ptosis surgery. Father, Dr. Hisham.
Today I'm going to talk about the use of levator and levator muscle and the frontalis muscle in ptosis surgery. This patient had severe ptosis, had ptosis with poor levator function due to partial third cranial nerve palsy, and she had frontalis suspension for this. The left eye shows the good correction on the left side. Usually we have to discuss with the patient before the surgery what he would expect after the surgery. So what happens when he looks down and what happens when he looks up, because everything you explain to the patient after the surgery is a complication. But if you explain everything to the patient before the surgery, it is part of his disease. So this nice results is not that nice if we make the patient look downwards, because she will get some sort of lead lag. This is another girl. She had a very good correction with frontalis suspension. Even the scars on the brow are not seen. But if she tries to look upwards, then the ptosis reappear again because she cannot raise the eyelid. And then if she tries to look downwards, she will get this retraction. If we don't explain this to the patient before the surgery, then it is considered as a complication rather than a part of the disease. When we examine a patient like this, she came with congenital ptosis, and we can see that she has got some sort of deficient eyelid closure in the ptotic eye. I usually follow this scheme. This is my own scheme on evaluating patient with ptosis. I look for the levator function. If it is good levator function, 12 millimeters or better, then I am satisfied. I'll tell the patient that he will have a very good recovery. He will be able to open the lid, close the lid, and will have no exposure to the cornea. Then we assess the degree of ptosis. If it is more than 2 millimeters and there is evidence of dehiscence in the aponeurosis, like the presence of elevated superior eyelid crease, then we'll go for repair of this aponeurosis. Usually the history will show that the patient, either this is involutional ptosis or there is some sort of blepharochalasis. But if the ptosis is minimal, 2 millimeters or less, and there is no evidence of aponeurotic dehiscence, the patient give very good response to phenylephrine, then we can do mullarectomy or Fasanella Zerbat, whatever you prefer to do. When levator function is poor or fair or moderate, 12 millimeters or less, then we'll reassess this levator function. If it is less than 5 millimeters, then the patient will go for brow suspension. All these techniques do not need actually titration. For example, aponeurotic repair, you just open and see the defect and repair the defect. In mullarectomy, we just do some sort of mechanical cut of 4 millimeters fold of the molars muscle, and then you don't titrate it very much. For the brow suspension, we usually leave the eyelid margin to the on the upper limbus. But the problem actually with patients having levator function of moderate to fair amount of fair affection, which is between less than 12 and more than 5 millimeters. We do levator resection for these patients, and this surgery is critically will need adjustment or titration. How to estimate the amount of levator resection? We can estimate the amount of levator muscle that we resect by going back to formulas like Beard formula and Mark Levin formula. This formula shows amount of required levator resection in millimeters for a specific levator function and degree of ptosis. This modified table showing the levator function in millimeters, good, fair, and poor, against the amount of ptosis, mild, moderate, and severe. For this Beard formula, this is one of the first formulas published. And usually, if you follow these formulas, you'll get overcorrection if you follow this formula in this category of patients. This is in my hands. And for Mark Levin formula, which less aggressive than the previous formula, you will get undercorrection in these patients who have severe ptosis and fair levator function. The difference between these two formulas that in the Beard formula, he put the poor levator function 0 to 5 as part of his correction with levator resection. Probably he is using maximum levator resection in these patients, but in Mark Levin, he just excluded these patients and considered that less than 5 millimeters levator function is better be done by Frontalis suspension. And then he separated the fair levator function here in Beard formula into two groups, moderate and fair, according to the amount of levator function, residual levator function. As you have seen that in my hands, if you follow these formulas, sometimes you get overcorrection or undercorrection. So there is a need in doing levator resection to have on-table titration. And the Burke technique will use the amount or describe the amount of cornea that should be covered by the eyelid under general anesthesia. The trick in this technique is that you need to put the eye globe in the straight position of gaze or primary position of gaze during surgery. For example, if the patient have got a levator function of 10 millimeters or more, then you leave the upper eyelid margin 4 millimeters below the limbus. If it is 8 to 9 millimeters of function, then you leave the upper eyelid 3 millimeters below the limbus, and so on. And if you find a patient having levator function of 4 millimeters or less, then you will go for Frontalis suspension. This is the way that described by Burke to dissect and then resect part of the levator by pushing. First of all, we have to put the lid in straight position gaze. Then we dissect the levator and push the eyelid to the level that we want. Then mark where the levator should be sutured to the tarsus. The problem with this technique is that you should put the eye globe in the primary position of gaze during surgery. So either using formulas, using the Burke technique, or using the gap technique. The problem of Burke technique is that it doesn't consider at all the degree of ptosis. It just considers the amount of levator function, and according to this levator function left, we put the upper lid margin. There is another technique which is called gap technique. The gap technique will consider levator function and will consider the amount of ptosis at the same time. I leave Dr. Hisham Farouk to explain this because he uses it a lot. I'll stop sharing.
I'm not to stop sharing.
Okay. Dr. Hisham, please explain to us what do you do with this gap technique?
Okay. As a matter of fact, there are two schools to deal with the levator excision under general anesthesia. The first one, as Dr. Hisham mentioned, which was devised by Bert, and this depends on measuring the amount, how much levator should be excised to reach the optimum position of the eyelid postoperatively. And the second one by Berke, which doesn't depend on the amount of how much we remove of the levator, but rather on the gap of the lids under general anesthesia. As a matter of fact, I'm using this technique now for more than 20 years, and it is highly predictable. Though simple, it is very simple to predict the postoperative lead height. And it is incorporated under different levels of levator function. The formula, as Dr. Hisham mentioned, is we measure the separation of both leads under general anesthesia. And if we have a good levator function, we add 3 millimeter to the amount of preoperative ptosis, while in fair levator function, we add 4 millimeter to this amount. The beauty of this technique is that it neutralizes many surgical variables. One of the techniques that Dr. Hisham mentioned is that where you will put the upper eyelid according to the limbus, the superior limbus under general anesthesia. As you know, under general anesthesia, sometimes the anesthesia can go lighter and the eye will shoot up. And so you cannot exactly define where to put your upper lid margin. Here, all these variables are canceled and you only measure the distance between both lids. I have a video here. It's about 7 minutes, but I will try to run it faster in 2 or 3 minutes to show you the technique. So we start by measuring and drawing the incision line at the crease. And then as we dissect through the orbicularis, the orbital septum, and we expose the preaponeurotic pad of fat. And then here we take our first stitch, which is the central lifting suture, just nasal to the edge of the pupil in the upper third of the tarsus, and we make sure that our stitch does not transfix the tarsus, so that it will not project to rub against the cornea. And our second stitch is at the lateral limbus. The same, make sure that it didn't pass. And then we take our stitch somewhere in the levator without measuring, and we take a releasable stitch using the 5/0 Dicron sutures. And then we note the contour. As you see here, the contour is not perfect. There is some notch here. And the second is the gap. If the contour is not perfect, we can add another stitch to adjust the contour. And again, we take a releasable knot through the 3 stitches. Now the contour is much better. And then we measure the gap. Here it's 8.5 millimeter. We can adjust it, either we can make it higher or lower until we reach the planned gap between both leads. And then after attaching, taking a surgical knot at the end, we can make a mini blepharoplasty here, very small blepharoplasty. And then taking our supratarsal fixation using 7/0 Vicryl through the orbicularis and the levator aponeurosis. And finally, we close the skin with running stitches. And this is the end of surgery. Very simple, only to measure the distance between both leads under anesthesia. Using this formula, actually, more than 95% of patients, they enjoy satisfactory postoperative eyelid level, which is excellent or good, for more than 20 years now. I will show you rapidly some of the cases pre and post-operatively. You will see that different levels of ptosis, mild, moderate, severe, okay, like this patient, and this one, mild ptosis, but perfect correction post-operatively. If you have, like this one, small blepharochalasis, you can correct it also by blepharoplasty during surgery, bilateral, unilateral, and we get finally this beautiful smile of the patient post-operatively. Thank you, Dr. Hisham, for allowing me to share this experience of the gapping technique.
We'll go back for my presentation. Usually I get to the theater in mind with the formulas in my mind. And these formulas with experience will modify what you want to do. So I go for BIRD formula for higher, if I need much resection, and for Levine for a smaller angle, for smaller degree of ptosis, or with good levator function. At the same time, while I'm in the surgery, I use the BIRD technique and I use the gap technique as well. Sometimes they are not all going together, and sometimes they are all going together. With experience, you then decide which technique you will choose to take the final decision where to put the eyelid. Ptosis with poor function can be corrected by Frontalis suspension, maximum and super maximum levator resection, or Frontalis flap. Frontalis suspension is the gold standard treatment for severe ptosis with poor levator function of less than 5 millimeters. It entails the use of suspension material or a sling to lift the eyelid. The sling is attached superiorly to the frontalis muscle, and there are so many techniques of fixing the eyelid to the frontalis muscle. This is the crowfold technique, and this is the Fox pentagon, which are the most famous among the other described techniques in literature. The logic behind using the frontalis muscle to raise the eyelid is to achieve elevation of the ptotic eyelid. If we can look to the right eyelid, and then this is at the same time, the frontalis will give us a chance to acquire some upward movement with raising the eyebrow, like in the left eyebrow, the left eyelid in this patient. The last thing, it will allow us to achieve some sort of closure when the patient actively contracts his orbicularis muscle, which is not achievable in other techniques like super maximum or maximum Levator resection. The sling material, the gold standard sling material is the autogenous fascia lata, but the problem with autogenous fascia lata, it takes a long time during harvesting it, and there is a possibility of donor side morbidity. There is also an age limit. We cannot have fascia lata below 3 years. Some say 1 year, but it is going to be more difficult to the younger the child is. So many of us are using synthetic material, and I have seen a lot of problems with different types of synthetic material. I'm happy with this elastic material and happy with the Gore-Tex. This is a picture of some of what I have seen coming back to me, and because of poor insertion of and coverage of the sling material, in addition to inability to disinfect the sling material before inserting it. So there is another problem with frontalis suspension is that you can get contour anomalies and asymmetry between the left and right eye. Also, with time, we can find the sling cheese wiring upwards, and the effect of surgery will decrease by time. There are some alternatives to frontalis suspension with the maximum and super maximum levator resection. Resection of 30 millimeters of levator with or without suturing it to Whitnell's ligament. It achieves reliable eyelid elevation with low recurrence rate. It is much easier to achieve regular eyelid contour and good upper eyelid crease. So why don't we use it all the time? Because it produces a frozen look eyelid with little mobility. As I said, in frontalis suspension, the patient will be able to close the eye voluntarily with contracting the orbicularis. There is a high incidence of exposure keratopathy with this technique. So we can avoid this by compromising the amount of lid lift during this surgery. Another alternative is using frontalis flap. Probably Dr. Ibrahim Allam has got some experience with this technique. It is the dissection of a flap from the frontalis muscle and passing it under the skin to be attached to the tarsus like this. You can have this frontalis flap either through a separate wound above the brow or from the eyelid crease incision, and you dissect it upwards. The advantage of this technique is that you use a locally available autogenous material. You don't have to open the leg or get the fascia lata, but under correction is common and recurrence is common. And this is how the flap is attached to the tarsus. We'll go back for the frontalis suspension, which is the gold standard for lifting a ptotic eyelid with poor levator function. The disadvantages of the current technique, as we have seen, asymmetry, irregular eyelid contour, wound reaction, sling material problems, slippage of the frontalis sling, leg ophthalmos, and regression of lid elevation. To achieve a successful surgery, we have to achieve certain goals. Lid function, this surgery should provide adequate corneal protection and achieve reasonable eyelid elevation. This is the lid function. Cosmetic outcome, it keeps symmetry and avoids the lid distortion like hooding. Hooding, this is just a folding of the skin. When you raise the eyelid upwards, then the extra skin will fall downwards. Notching, lid crease disorders, and sagging. Avoid sling complications like extrusion, infection, migration, granuloma formation, and have low recurrence rate. I'm going to speak about two modifications I developed for this surgery. First of all is using the levator muscle itself as a sling for the frontalis muscle. And in such technique, we take the distal part of the levator muscle that is not functioning, or when there is a need to separate the levator muscle, as in cases of Marcus-Ganjo winking phenomena, and redirect it to be attached to the frontalis muscle directly. So the distal part of the levator is used as a sling to be attached to the frontalis. And this is how the surgery is done, through a upper lid crease incision. Then we dissect we cut the levator in the orbit from the levator aponeurosis from the rest of the levator muscle, and dissect it freely, but leaving it attached to the tarsus. Then having an incision above the brow to redirect this flap from the distal end of the levator to be attached to the frontalis muscle. And here, the levator muscle, the distal part of the levator muscle is attached to the frontalis. And this is very good in cases of Marcus-Ganjo winking phenomena, because it ensures that the abnormal movement will be abolished. We usually leave the lid margin near at the upper limbus or near 1 millimeter below. This patient has a very minimal scar of above the brow. This means that it doesn't leave a significant scar, and as you can see, he had severe ptosis. Using the levator as a Frontalis sling, it uses a readily available sling material, avoiding additional incision required for tissue harvesting. It has the advantage of being an autogenous material in addition of being a local flap. The aponeurotic flap is attached to the tarsus at one end and is naturally involved in the mechanism of eyelid elevation. It is strong enough to support the eyelid and to transmit frontalis action at the brow. It is well documented that cutting the levator aponeurosis at weakness the ligament and transposing it anteriorly towards the orbital margin have a less rate of recurrence of Marcus-Ganjo winking phenomena than mere excision of the levator. And as we can see here, the patient before the surgery has got Marcus-Ganjo winking phenomena with significant ptosis. And on the right side, with the movement of the jaw, that the ptosis was corrected and there is minimal scar above the brow. The disadvantage is it sacrifices any residual levator function. However, this approach is reserved for extremely poor levator. A good eyelid position is best achieved when the patient is attentive and raising his eyebrows. The lower eyelid position at rest is acceptable in bilateral cases, but might compromise cosmetic symmetry in unilateral procedures. Another modification which will help us to adjust the lid contour and avoid some of the asymmetry that develops after such operation is using the Whitnell ligament as a fulcrum to redirect the frontalis suspension into the surgery. What is done differently in such technique? We do a limited upper eyelid blepharoplasty to avoid the occurrence of hooding. I usually soak sling material in garamycin, and most of the time I use Gore-Tex. Then I fix the sling with suture to the tarsus. I suture it to the tarsus. In the classic technique, we just pass it in front of the tarsus. Passing the sling under retinal ligaments so that we change the force of direction, the direction of the force from being just straight upwards towards the frontalis muscle to be curved backwards towards the retinal ligament before being attached to the frontalis muscle. Formation of eyelid crease, because we open the eyelid crease, that we can form the eyelid crease and give better cosmetic results. These are the incisions that we use, 3 brow incisions and 1 eyelid crease incision. The vortex or the sling, whatever we use, is fixed to the tarsus with separate sutures, and then it will be passed underneath the retinal ligament before it appears in the superior eyelid wound. The advantage of this technique is that we can adjust the eyelid contour when we are fixing the sling. We can have a good eyelid crease. We avoid the occurrence of hooding, and we prevent sling migration by suturing directly to the tarsus. Sling complications are less common when they are soaked in garamycin, so I keep using antibiotic soaking solution before inserting the sling. The disadvantage of such a technique, it is time consuming because you do a lot of steps rather than just passing the sling directly. And then the patient will still suffer from a nocturnal lag of thalamus and upper scleral show on down gaze. A lot of modifications are have been described for this technique, and we are actually under or experimenting other ways of improving our frontalis suspension technique. Thank you for your attention.
Thank you, Dr. Hisham, for your nice presentation. And now I invite my dear friend, Dr. Ibrahim Yahya Alam, to present his talk about decision-making in severe ptosis surgery. Further, Dr. Ibrahim.
Thank you very much, Dr. Hisham, for your nice presentation, and Dr. Hisham Ali for the really illustrative presentation also. My talk is about decision-making in severe ptosis. Here, the aim of the talk is to show how to diagnose and do a proper management plan for severe ptosis in different situations. As we all know, ptosis is classified etiologically into the common types: myogenic, neurogenic, aponeurotic, mechanical, and traumatic. Non-etiologic classification is congenital. This is mainly myogenic in nature and acquired for any etiologic cause. Severe ptosis can be the manifestation of any type of these above etiologies. Starting from congenital ptosis, there are 4 presentations of congenital ptosis: simple congenital ptosis with elevation deficits, ptosis with blepharophimosis syndrome, and ptosis with Marcus-Gunn phenomenon. In simple severe congenital ptosis, it's not always simple because of the risk of amblyopia and abnormal head posture, the difficulty in assessment in infancy, and sometimes we need very early surgery. The risk of amblyopia is alarming because of the high frequency of the refractive errors, especially anisometropic astigmatism, which is the leading cause of amblyopia. Visual deprivation is the cause in a small percentage, and in most studies from 2 to 12% only. So we consider more than 1.5 diopter cylinder is amblyogenic to these children, and the risk of amblyopia increases with decreased palpebral fissure heights. The child in the extreme right is very vulnerable for amblyopic insults. So early surgical intervention followed by cycloplegic refraction, optical correction, followed by aggressive amblyopia therapy is indicated. Bilateral severe cases also are subjected to refractive amblyopia. And of course, abnormal head posture may be present in some children. The second type of congenital ptosis is ptosis with elevation deficits, like the classic example of monocular elevation deficiency, or what we call double elevator palsy. This child is prepared for squint surgery, not for the surgery first. He has right severe ptosis with primary gaze hypotropia and limited supraduction. The surgical decision starts with squint surgery first, muscle transposition of NAP, plus or minus inferior rectus recession. We do forced abduction test. If the inferior rectus is fibrotic, this is a restrictive element and should be released. And hence the name monocular elevation deficiency is more accurate than the double elevator palsy, followed by ptosis correction later on. The third type, and my dear brother, Dr. Ihab Osman, will talk about Marcus Gunn in details. However, it's the classic example of synkinesis or abnormal innervation connecting two groups of normally unrelated muscles. It's most often is the result of contraction of the external pterygoids, rarely with teeth clenching with the use of internal pterygoids. This is an example of synkinesis with external pterygoid muscle, with mouth opening or jaw movements. This is a good sign during anesthesia. During induction of anesthesia, you will notice a twitching movement in the ptotic eyelids. This is a rare type of synkinesis to internal pterygoid muscle with clenching, and rarely sometimes present with Duane retraction syndrome. The wing is considered significant if more than 2 millimeters, maybe moderate wing, or sometimes severe wing up to more than 6 millimeters. The fourth type of congenital ptosis that may be severe is the blepharophimosis ptosis Epicanthus Inverses syndrome, and Dr. Hisham Idris discussed the problem very nicely. We have the 4 cardinal signs of blepharophimosis: ptosis, blepharophimosis, Epicanthus Inverses, and telecanthus, sometimes with hypoplasia of the superior orbital rim, lateral eyelid ectropion, and hypoplasia of the nasal bridge. They exhibit various severity and the phenotypic expression. Our concern is the severe ptosis that may be present in some patients. It's important to differentiate from Waardenburg syndrome, which has heterochromia, severe telecanthus, and the blepharophimosis, but with very good levator function, and the patient here is not in need for any ptosis surgery. When examining a severe ptosis, we should check the MRD2. The levator function should be less than 4 millimeters. The skin crease is usually absent. Palpebral fissure heights, if less than 2 millimeters, we consider it a very severe ptosis. Also, we should check for lag of thalamus, Bell's phenomena, and the dry eye if possible. So, what is the choice of surgery? What is our decision for surgery in congenital ptosis? In simple severe ptosis, we go for frontalis suspension or supramaximal levator resection. I'm not going into surgical details, but because the talk is a little bit long, so we're going to jump over the details of surgery. Options for frontalis suspension are slings, very popular, like silicone, Gore-Tex, donor fasciolate in children, frontalis muscle advancement flap, and the technique of levator muscle advancement, as Dr. Hisham Ali clarified. Silicone slings is very popular. Silicone rods, it's very common. Sometimes we use silicone bands or silicone rods fixed to a sharp needles. We call it safe slings. Also, different techniques of frontalis suspension. These techniques are surgeon dependent according to the surgeon preference. This is example for silicone bands. The broad part is fixed to the tarsus. and the bands are fixed in the same pentagon or Fox pentagon pattern. The Frontalis suspension sets of safe, this is sharp needles fixed to the silicon rods, and this is a closed Frontalis suspension. Single forehead incision, and the needles, a sharp needle pass through submuscular through the tarsus along the path of the pentagon to be fixed in the forehead pockets. The results are acceptable. It's a little bit expensive, but the results are acceptable. This is an example for silicon rods open technique. It's very popular to use silicon rods. Usually I use the triangular pattern. Long time I prefer the triangular pattern better than the double triangle of Crawford. I don't have any contour problems with the triangular pattern of Frontalis suspension. Here is another example with very smooth lid margin with no notching or contour abnormalities. This is a last example. And lack of thalamus usually disappear within a few weeks. There are some complications for slings, as Dr. Shamali mentioned: infections, granulomas, maybe slippage, lack of thalamus. So we can use other techniques like Frontalis muscle flap. I have a long experience with it with good results. Simply, we expose the superior orbital limb and we fashion in the middle third of the Frontalis a rectangular or tongue of the Frontalis to be fixed to the levator and the upper edge of the tarsus with good results and long-lasting results. So when to deal with simple severe ptosis, the decision is as follows. Early intervention, especially in unilateral cases, we go for Frontalis suspension or supramaximal levator resection. It's important for cycloplegic refraction and post-operative occlusion therapy if needed. In special situations like blepharophimosis, we go for Frontalis suspension. It's better to be staged procedure with correction of the epicanthus and pericanthus followed by ptosis correction by the age of 4 to 5 years. However, sometimes you need early intervention and one stage procedure may be used. This example for epicanthal treatments, I like the OIV procedure. It may be CY or double Z of Speth or Master Day with medial canthus plication or transnasal wiring. Sometimes we are confronted with this severe form of ptosis. We have to interfere very early, although the results are not optimum, but the aim is to clear the pupillary axis followed by refraction. The incidence of refractive errors is very high in blepharophimosis syndromes. This is another example of one-stage procedure, and the intercanthal distance in relation to the interpupillary distance nearly became half. And this combined procedure, YV with bilateral Frontalis slings. In severe congenital ptosis Marcus Gun, this is another situation. We have to obliterate the levator function to dampen the apparent eyelid movements. Many procedures described for severe cases, mild or moderate cases, no problem for correction, but in severe cases, it's a real trouble. Complete excision of the levator is described all the way to the orbital apex. Sometimes removal of portion of the levator muscle above the Whitnell ligaments. Unilateral levator excision with bilateral Frontalis suspension, or bilateral excision of the levator and the bilateral Frontalis suspension. For symmetry, the best is to do bilateral excision of the levator muscle and the bilateral Frontalis suspension. The main problem of this procedure is to convince the parents to work on the sound eye. This example of bilateral levator excision and the Frontalis muscle advancing flap, we detach the levator from the tarsus and we suture the Frontalis flap to the tarsus. Here is some examples. The wing disappears with good symmetry of the eyelids. You can use in one side a levator sling material, silicone sling, and the other eye Frontalis flap the principle is the same, is to depends on the frontalis with cutting or extirpation of the levator muscle. When you come to the acquired severe ptosis, for diagnosis, we should take a very good history for the onsets and the course, history of trauma, and history of systemic manifestations, drugs and diseases, with detailed examination and imaging. This is the first example of acquired ptosis in a child. 10 years old female child, 1 month history of acute ptosis. Anterior posterior segments examination is unremarkable. There are left severe ptosis with poor function, normal pupillary reaction, and delimited supraduction. The patient disappear and come after 2 months with left esotropia and binocular diplopia, with adding limited abduction to the supraduction deficits. MRI brain and chest were free, negative tensilon test, but she has a positive acetylcholine receptor antibody. This is an example of acquired myogenic ptosis in a child. The child once take the pyridostigmine or mestinone and the steroids, it improves in a matter of 1 or 2 months. She was diagnosed as prepubertal juvenile myasthenia. Myasthenia, as you all know, we have generalized myasthenia, ocular myasthenia, and if the respiratory muscles affected, this is a myasthenic crisis. The ocular myasthenia to be diagnosed should be of ocular symptoms for 3 consecutive years to judge is it purely ocular myasthenia. In children, like in our example, we should differentiate between 4 types of childhood myasthenia. Neonatal, this is transient due to maternal myasthenia. Familial infantile type, onset very early, before 1 year of age, usually generalized with positive family history. Congenital myasthenia syndrome, it's not autoimmune. There is a genetic mutation in the neuromuscular junction, negative antibodies, and present in the first few years of childhood. Juvenile, like our case, the same presentation as an adult type. It's an autoimmune with positive antibodies. This is another example of myogenic ptosis in a 4-year-old child with bilateral severe ptosis since 1 month. There is diurnal variation. There is negative acetylcholine receptor antibody. Look at this sign. When the patient looks down for a while, then look up, there is overshoots of the upper eyelids. This we call a Kogan twitch sign. It's diagnosed as congenital myasthenia syndrome. And here is after mestinone and steroids, the patient is doing well. To diagnose myasthenia in general, the diurnal variation is important. IcePack test, very simple test in the clinic. It's 5 minutes application of ice packs. At least 2 millimeter improvement is enough for diagnosis. Tensilon test. The antibodies don't depend or rely much on the antibodies because 80% of adults with generalized disease have the antibodies, and only in 55% of ocular myasthenia. Anti-muscle specific kinase is another antibody. Electromyographic studies, CT chest for thymomas, and thyroid functions because there is an instance of thyroid eye disease with myasthenia gravis. This example for IcePack test. Unfortunately, the patient also has a thyroid eye disease. This is another example of IcePack. 5 minutes application, 2 millimeter improvements is sufficient for diagnosis. How to treat? The first line of treatment is anticholinesterase inhibitors. As you know, the mestinone, 4 to 6 times per day, then tailored according to the condition. Children dose is 0.5 to 1 milligram per kilogram per dose. The maximum is 7 milligram per kilogram per day. Immunosuppression with steroids or azathioprine or cyclosporins or tacrolimus. Thymectomy is not the magic solution. It's used in the refractory cases in acetylcholine receptor antibodies positive patients, and it's not proven to protect against progression to myasthenia gravis. Role of surgery, our decision of surgery in myasthenia gravis. we should weigh the risk versus benefits. They have impaired Bell's phenomena, infrequent blinking, severe dry eye, risk of frank post-operative lag of thymus, but the patient when is functionally blind, we should think of solution. The aim is to undercorrect his ptosis to avoid complication and exposure. Check for muscular diplopia. If the patient has diplopia, we can operate in single eye. Our choice is Frontalis suspension. No rule for resection. It's usually a failure in cases of myasthenia gravis. We aim usually at undercorrection. We did a Frontalis muscle flap with just exposure of the pupillary axis. Another example of myogenic ptosis is chronic progressive external ophthalmoplegia. It's a bilateral, symmetrical, with progressive ptosis, followed by ophthalmoparesis months or years later. The pupillary reaction are normal. We have the same manifestations, but plus disease. There is involvement of systems other than the muscle, example, Kearns-Sayre syndrome. Their definitive diagnosis is muscle biopsy. We find what's called the erect red fibers due to abnormal skeletal muscle mitochondria. It's a mitochondrial inherited disease. It means it's transmitted through the mothers because the sperm has no mitochondria. It's only present in the ovum. This is an example of chronic progressive external ophthalmoplegia, onset between 20 to 40 years. The patient usually came to you by the age of 40 or 50s with ophthalmoplegia and symmetrical ptosis with no associated ocular manifestations. Kearns-Sayre syndrome starts before the age of 20 years, starts very early with pigmentary retinopathy and at least one of the following. This is very important. Cardiac conduction abnormalities. The patient may die from cardiac arrest. Ataxia and high CSF proteins. What's our decision if the patient is visually crippled? Sometimes we see the patient with severe ptosis, overacting frontalis with severe headache by the end of the day, and the chin elevation. This is called Hutchinson triad. Again, like myasthenia, we aim to clear the pupillary axis. Frontalis suspension is our choice, and take care for exposure. The patient should have frequent lubricants and watch for exposure frequently. In Kearns-Sayre syndrome, watch for the ECG of the patients because the patient may go in problem during general anesthesia or in their life. They may exhibit a sudden death. The second category of severe ptosis is the aponeurotic one. The most common cause is senile, as you know, maybe post-operative or post-traumatic or due to chronic irritation. There is a triad of high lid crease, good levator function with thinning of the eyelid superior to the upper tarsal plate, maybe bilateral symmetrical, or rarely it is unilateral. They exhibit a very deep sulcus, but watch out for other senile lidded changes. This patient, if you observe, he has an adhesive strip to pull the lower lid margin away from the globe. What is our decision in such cases? The aim is aponeurotic repair, transconjunctival or transcutaneous. If associated with peripheral kinesis, we go for anterior approach. Like these patients, we need to remove the fat pockets and the excess skin, or transconjunctival, like in this lady. As a matter of fact, when we expose the aponeurosis, there is a very wide gap between the upper edge of tarsus and the levator aponeurosis. Just repair of the aponeurosis is sufficient to correct the ptosis. I'm here, I get the permission of the patient to expose the whole face. These patients are, beside the functional abnormality, they have a cosmetic problem, and they have very poor quality of life. Post-operatively, it's actually rejuvenating the patients. And as can you see, after repair of the entropion and the aponeurotic ptosis, the patient quality of life much improved. Sometimes the aponeurotic ptosis is post-operative. We all see the post-operative cases, and we wait for 3 months before any intervention. The high lid crease is diagnostic. It can be severe in old age, and it may present post-blepharoplasty surgeries. Again, repair of the aponeurosis through anterior approach or posterior approach is quite enough. The third category of severe ptosis is mechanical one. The treatment is simply treatment of the cause with some precautions. Congenital, the classic example is capillary hemangiomas. We go for systemic propranolol or intralesional steroids to correct the ptosis rapidly. Maybe inflammatory, infective, non-infective, like steroids in idiopathic orbital inflammation, the patient ptosis disappears. Neoplastic may be benign, like neurofibromatosis, but take care to proper ocular examination, CT, brain and orbit, for diagnosis of any associated gliomas or meningiomas, treatment excision with or without Levator surgery. Here is another neurofibromatosis, simply excision of the mass effect of the upper eyelid will elevate the eyelids. Another example, take care to examine the globe. Here the globe is found to be sunken. Severe enophthalmos with diplopia. CT, you can find this picture. Deficiency of the greater or absence of the greater wing of sphenoids. It occurs in 3 to 7% of patients. This orbital fat herniation in the middle cranial fossa. Sometimes the opposite. Sometimes the brain tissue prolapses through the orbit and the patient presents with exophthalmos and pulsating. In this condition, no. He has herniation in the middle cranial fossa. Surgery is split bone grafting and repair of the anterior skull-based defect. For us as ophthalmologists, don't try to elevate because of the diplopia. Just excise for cosmetic reasons. Orbital tumors can cause ptosis, like sphenoid wedge meningioma, pressing on the superior orbital fissure and causing complete ptosis. Malignancy, don't forget to image the orbit in case of acquired ptosis, especially with some proptosis in children. This is a classic case of rhabdomyosarcoma before and after treatments. This is another case of rhabdomyosarcoma with palpable mass anterior in the anterior orbits, so it's involving the medial rectus muscle. Blepharochalasis may be severe enough to obscure the visual axis. This patient is one-eyed. She has left amblyopic eye with severe ptosis. As you can see, the lid crease in place. The lid crease, this is not a aponeurotic one. This is a purely mechanical one. And it took the patient around 3 years for decision for surgery. When the visual axis is getting worse and the vision is starting to decrease, she goes for surgery, and the results were okay for her as a visual rehabilitation. Another group is traumatic one, and take care when you are confronted with prolapsed orbital fat. This is surely a Levator injury is present, or in severe injury, or in foreign body in the upper eyelids. The bad management will give us this result. Very bad scar. It's very difficult to reoperate because of the removal of this scar tissue. So you have to repair meticulously, layer by layer. We wait for 6 months. Later on, scar revision, and usually Frontalis suspension is needed. Blunt trauma may be a cause of severe ptosis without any obvious wounds. Again, we wait for 6 months before operating. Here, we use a scar revision before surgery with Frontalis flaps also. Unfortunately, the patient has some exposure post-operatively because of the severe scarring. The last group is the neurogenic one. It's an important group of ptosis. It's the last one. The third nerve palsy has its etiologic classification as ischemic, traumatic, or post-intracranial surgery. And it has a clinical classification as total with pupil sparing, partial, or pupil involving. Pupil sparing, we see it frequently, usually macrovascular in nature, and occurs in vasculopathies, especially diabetic patients. Our decision is to observe daily for 5 to 7 days, looking for the pupillary reaction, MRI in young patients, and we check every 4 weeks. If the function is not regained after 3 months, MRI and refer to an internist. But this is the classic scenario. After a few weeks or 3 months, the patient regains his full function. The partial one, maybe of microvascular etiology or multiple sclerosis. It may indicate an evolving process from expanding intracranial aneurysm. So it is serious. All such patients require immediate neuroimaging regardless of the age of the risk factors present. This case was multiple sclerosis and improved after a few weeks. Pupil involving, this is a true ophthalmic and neurosurgical emergency, and MRI is surely indicated to disclose the cause of this total ophthalmoplegia. What is the treatment plan? Our decision: we treat the cause, wait and follow for 6 months, examine other cranial nerves before surgery, especially the 5th nerve, squint surgery first, then frontalis suspension. The squint surgery options is difficult. It's one of the most difficult squint surgery to correct. Many surgeries, maximal resection and recession of the medial and lateral recti. This is the classic surgery. Usually, it's not working well in most cases. Medial rectus periosteal fixation with lateral rectus insertion gives a good results. We remove the caruncle. We open an incision like the extended BCR incision. We expose the posterior lacrimal crest, and we pass the medial rectus below the caruncle and fix it to the posterior lacrimal crest. The globe is frozen. So you should be careful when correcting such cases. Frequent follow-up and frequent lubricants. This patient has frontalis suspension following muscle transposition. Muscle transposition is a heroic procedure. The lateral rectus is split and passed below the superior and inferior rectus to be fixed to the medial rectus. The whole globe is shifted centrally and fixed in the central position. As you can see, there is an ophthalmoplegia. So when correcting such ptosis, should be very careful to undercorrect, close follow-up, and watch for exposure with frequent lubricants. The patient is pseudophakic as well. As you can see, there is lag of thalamus in the first few weeks, decreased later on, but there is a lag of thalamus initially, and the pupil is dilated, fixed. When we are confronted with combined fifth nerve palsy, it is serious. You better not to operate. Why? We expect exposure. If you have to go through surgery, frequent lubricants, close monitoring, and be ready for redo surgery. We can release the frontalis suspension immediately if we confronted with exposure. This is a post-neurosurgical procedures, and this is following severe head trauma. These are the cases which we can see both third and fifth nerve palsy at the same time. This is another category of neurogenic ptosis, is the benign essential blepharospasm. It's a bilateral condition. It's a form of focal dystonia, and they're not associated with another disease. Sometimes the eyelid is totally ptotic, and the patient cannot open his eye. If spreading to the lower face of the neck muscles, sometimes we call it Meigs syndrome. How to treat? Botulinum toxin is the first line of treatment. Oral medications or drug therapy, its result is guarded. Facial neurectomy may be used, but with guarded results. Protractor myectomy or extended myectomy to remove all the orbicularis fibers, and sometimes the procerus and corrugator are also removed. this algorithm for treatment of benign essential blepharospasm, our target is the pre-tarsal orbicularis. These are 3 common injection sites, medial and 2 lateral. Avoid the central one, not to induce ptosis. Assess for additional symptoms. If there is still dry eye symptoms, because there is association between dryness and essential blepharospasm. If there is still dry eye symptoms because of abnormal blinking mechanism, you go for additional injection points at the medial lower pretarsal. If the spasm is still present, you go and inject the preorbital orbicularis. 1 to 4 injections in the lateral one and 2 or more in the superior one. This is a picture of protractor myectomy. It's a very tedious procedure. We remove every piece of the pretarsal and the preseptal orbicularis and part of the orbital orbicularis. The extended one, we remove also the corrugator and the procedures. The last case of neurogenic ptosis, it's ptosis with intermittent diplopia. This 26 years female with 6-month history of drooping of the left upper eyelids, sometimes severe, intermittent diplopia lasting for a few minutes with no diurnal variation. The patient has limited abduction. Her abduction is okay, but when regaining the primary position, the convergence persists. And also limitation of abduction is very increased. It was a little confusing. MRI brain was free. No acetylcholine antibodies was present. No other systemic manifestations. Eye speck test was negative. In literature, we discovered this is called an ocular neuromyotonia. It's a rare disease. It's an ocular motor disorder characterized by recurrent brief episodes of diplopia due to tonic extraocular muscle contraction. It's a due spasm of 1 or more of the extraocular muscles and lasts between seconds and 3 to 4 minutes. Maybe idiopathic or postcranial irradiation, nerve compression, or autoimmune diseases. It's important to do MRI for such patients. Treatment is tegretol, carbamazepine. It's for a long time. The patient has the drug for life, and the patient exhibits a good improvement over time. So don't forget, the history taking is crucial for diagnosis of acquired ptosis. Be aware of dangerous ptosis like myasthenia gravis, third nerve palsy with pupil involvement, Kearns-Sayre syndrome with cardiac conduction deficits. Severe congenital ptosis also needs patience in assessment and looking for other anomalies. Severe ptosis is not always simple and sometimes challenging to correct. Thank you very much.
Thank you very much, Dr. Ibrahim, for this tour in difficult and severe cases of ptosis. And now we have the nice ending with Dr. Ihab Osman, who will speak about Marcus-Ganz phenomenon. And I thank the participants for waiting with us till the end. Thank you.
Thank you, Dr. Shem, for this nice presentations. I'm very honored to be here with you, all of you today, with my professor, Dr. Shem Farouk, Dr. Shem Ali, and my professor, Dr. Ibrahim Alam. First of all, we started talking about Marcus-Ganz as part of their presentations. So I'm going to proceed on with the presentation now. This is a case presentation about a child who came to me. He's a male child, he's about 5 years of age. He were complaining of left droopy eyelid. His mother came to us to the clinic complaining of the left droopy eyelid. On examination, the margin flex distance was about 4 millimeters in the right eye and about 2 millimeters in the left eye, about 2 millimeters of ptosis. The Levator function test was of good levator function, 16 millimeter on the right side and about 15 millimeter on the left side. This is the video of the patient. During examination, we noticed on asking the patient to move his mouth or to open and close, there is a wink in the left eye. Notice the wink or just the elevation, the rapid movement or rapid elevation of the left eyelid when moving or opening his mouth. It's going to be seen once more. Here, this is the movement of the left eyelid. Not with moving the tongue, just with moving the jaw. Can you see now the twitch or the movement of the left upper eyelid? So, what is this called? This is called Marcus Gunn phenomena, or also called jaw winking, or called maxillopalpebral synkinesis, or finally Marcus Gunn phenomena. This refers to the opening of the eyelid on movement of the jaw. Any opening of the eyelid on opening the jaw or movement of the jaw is called Marcus Gunn phenomena. And there are two types of the Marcus Gunn phenomena. One, when we move the jaw or open the jaw, this is due to relation to the external pterygoid muscle. And there is one when we clench the teeth, and this is related to the internal pterygoid muscle. So both of them will cause upward movement of the eyelid, because this is very important as the two types of the Marcus Gunn phenomenon. There are also other variants of Marcus Gunn phenomenon we're going to be discussing later. But the Marcus Gunn phenomenon, it is, I have to repeat and insist, it is the upward movement of the eyelids on movement of the jaw. If it is on opening the jaw or moving to the jaw to the side, this is due to the external pterygoid muscle. And if it happens on clenching the teeth or closing the mouth, this is due to the internal pterygoid muscle. What are the possible etiologies? According to the NORD, which is the National Organization for Rare Diseases, this is a disease that is rare in occurrence. It affects both sexes equally. It is reported in literature in about just 300 cases, but the occurrence with ptosis or with congenital ptosis is about 5 to 12%. So if we have congenital ptosis cases, we can find this phenomenon in 5 to 12% of them, but the reported cases in literature are just 300, and this is considered one of the rare ocular plastic disorders. The exact cause is still unknown. Usually it's sporadic and congenital anomaly in 50% of the cases, or more than 50% of the cases. A variant of this Marcus Gunn phenomenon is called the familiar Marcus Gunn phenomenon, and it is transmitted as autosomal dominant trait. We can have iatrogenic or traumatic causes or neoplastic causes that affect the facial nerve, and this also produces the Marcus Gunn phenomenon. The pathophysiology, the impetus arise from the jaw winking, arises from the pterygoid muscles, as we said before, and there's a balanced connection. It can occur, this connection, between the nuclei, between the third nerve and the fifth nerve, or infranuclear or in the peripheral locations. So we had to ask the mother whether the child has this condition since birth, and she said yes. Did he suffer from any injury or head trauma or any facial surgery? She said no, and the mother added that this child have been having this funny eyelid movement, especially when he was breastfed or fed with the bottle. Dr. Shamfru thankfully shared the video with me today in the morning, but it was on the laptop, and now I'm sharing from the mobile phone, so I missed the video with them. It is quite evident that the lid move upward with the suckling act with the breastfeeding or the bottle feeding. How can you elicit this jaw winking in your clinic? Just ask the patient to move the lips, sometimes whistling or smiling, clenching the teeth, chewing or puffing the cheeks can do the trick and open the eye with the jaw movement. It is graded into 3 grades. This is mild, less than 2 millimeter of elevation, moderate 2 to 5 millimeter of elevation of the eyelid when moving the jaw, and severe cases of Marcus Gunn jaw winking with more than 5 millimeter of the elevation of the upper eyelid. What else should we look for in cases of Marcus Gunn phenomenon? Okay, we should look for the extraocular motility. Why? Because there is sometimes superior rectus palsy, which is called double levator palsy. This is about 25% of our cases. We can have also horizontal squint, whether medial or lateral rectus, and this is 50 to 60% of the cases, and it can be associated with the Wayne retraction syndrome. So we have to look for the extraocular motility. Second, we should look for the fundus, because sometimes of these cases of jaw winking, we have cases of retinitis pigmentosa, or morning glory anomaly. Third, we should look for the vision, because all ophthalmologists, the main concern for them is the visual acuity. We have to exclude refractive errors because it's present in 5 to 25%, representing case of anisometropia. Also, we have to exclude amblyopia, which is present in a very high percentage, up to 60% of the cases. The things to add for our examination: the pupillary examination, the Bell's phenomena, the head position, and dry eye assessment. For our patient, all the findings are normal except for the jaw winking, and the uncorrected visual acuity was 612 in the right eye and 636 in the left eye. The best corrected vision, it was with the right eye 6.6, and the left eye it was 6.12, with this difference in correction. We should note one thing also in our presentation, is that patients with the Marcus Gunn phenomenon, or patients with ptosis, are sometimes having more astigmatic error in the ptotic eye, and this can be due to the effect of the heaviness of the lid during the development or during the cases of the ptosis stuff. So what will we do for our patient? Do we need to correct the jaw winking? Well, the treatment of Marcus Gunn phenomenon is usually not needed, because this tends to decrease with age. As the child grows older, the Marcus Gunn phenomenon tends to decrease, and we don't have to interfere in most of the cases. Psychological counseling for both the parents and the child, or sometimes the adult with the Marcus Gunn phenomenon, is very important. Why? Because these patients are urging the doctor to do a surgery, and they are convinced that this surgery will be curable for everything that they have in their minds. For the toes, it will be perfect. For the jaw winking, it will be perfect. And so we have to tell them what to expect and what to not to expect during the surgeries. We should have an algorithm for approaching the child with Marcus Gunn phenomena. So if we have a Marcus Gunn jaw winking which is less than 2 millimeter, or a mild case of Marcus Gunn jaw winking, we should look for the ptosis. If he has mild ptosis less than 2 millimeter, this child can be followed up safely with no problem. And when he's older, he can do a Fasanella Servat or a standard Levator resection. If this child has severe ptosis more than 2 millimeter, we are going to do a ptosis surgery. And we're not going to address the jaw winking as itself, because it tends to be lesser by time as the child grows up. And the ptosis surgery will be in the form of external Levator resection or bilateral Frontalis Suspension. However, if the Marcus Gunn jaw winking is more than 2 millimeters, this is a severe case of Marcus Gunn jaw winking. If he has mild ptosis, then we're going to postpone till the child is older, because we have no fear for the amblyopia for this child. And if the Marcus Gunn jaw winking improved, we have nothing to lose, and we're going to correct the ptosis surgery. But if the child has Marcus Gunn jaw winking which did not improve as he grows older, then in such cases we are going to do a ptosis surgery. If it's done alone, it's going to end up with more exaggeration of the jaw winking. So if you're going to have a child with moderate to severe jaw winking and mild ptosis, and you're going just to correct the ptosis without addressing the Marcus Gunn jaw phenomena, it's going to end by more retraction with movement of the jaw. So this is a dilemma for such patients. However, the problem is much simpler. If you have severe ptosis more than 2 millimeter, we're going to do rapid intervention for the fear of amblyopia for this child, and it is usually in the form of Levator resection on the affected side. We're going to remove the Levator muscle on the jaw winking side, and we're going to do Frontalis suspension on both sides. This will give the best cosmetic results. Dr. Sham Ibrahim and Dr. Ibrahim Alam also mentioned types of modification of the Frontalis suspension, whether with the Frontalis method, advancement, or with a sling. This can be according to the surgeon's preference and discussion with the patients and their relatives. What about our child? Did we forget anything with our child? The child had a ptosis surgery because it was mild Marcus Gunn, and we had the Levator resection for him, and he was happy and smiley. But, and this is a picture pre-operatively and post-operatively, but we shouldn't forget that the patient was amblyopic, a little bit amblyopic on the other side, and he should be wearing the glasses, and we should address the phenomena of amblyopia in such child to regain perfect vision for him, as he's still young and can benefit from the occlusion therapy. We mentioned before in the beginning of the talk that the Marcus Gunn, it is just upward movement of the eyelid when opening or closing the jaw or opening the mouth. It is an upward movement. There are other variants of the Marcus Gunn phenomenon. What are these variants? We have what's called inverse Marcus Gunn phenomenon. And this is a congenital disorder in which the eyelid levator muscle is inhibited by jaw movement. So there will be lid drooping or ptosis, more ptosis on jaw opening. So the Marcus gun, the lid opens when we open the jaw, while in the inverse Marcus gun, this is a congenital disorder in which the lid drops more with opening the jaw. We have also called the Marine-Amat syndrome, and this is the same as the inverse Marcus gun. The lid drops with movement of the jaw, but this happens after facial paralysis. So the inverse Marcus gun is reserved for the terminology of the congenital disorder, and the Marine-Amat syndrome is reversed for the cases of post-facial paralysis. There is also a variant called the oral facial digital syndrome. From its name, it is something related to the oral. There is an extra number of teeth, okay, and there is a congenital cleft palate. Facial, we have facial deformities, and we have the digital syndrome or digital part, which refers to the abnormalities in the hand and feet and shortened limbs. These child also can suffer from neuromuscular abnormalities as well as mental retardation in various degrees. The fourth variant is called the faciopalpebral kinesis, which is a rare disorder in which the upper lid moves upward when smiling. So it's not just opening the jaw, it is just a simple act of smiling and elicit this upward movement of the upper eyelid. So these are the four variants of the Marcus gun phenomena. We said the Marcus gun is upward movement of the eyelid, and there are two types. If we open the jaw, this is called, this is due to the external trapezoid muscle, and if we clench the teeth or close the jaw, this is due to the internal trapezoid muscle. And we have the inverse Marcus gun phenomena, as we said before, and we have the Marine-Amat syndrome. These are variants, the oculofacial digital syndrome, and finally the faciopalpebral kinesis. These are the four variants of the Marcus gun phenomena. Please take care that these kids or these congenital cases with Marcus gun phenomena have a typical ocular cardiac reflex and can be easily elicited in these patients, especially when they take anesthesia. So this can end by cardiac arrhythmias. So please inform any case of Marcus gun phenomena to the anesthesiologist during a surgery in order to avoid a cardiac arrhythmia and unfortunately a cardiac event that might injure or affect the child. Thank you for your attention, and I hope that you enjoyed the presentation. And I'd like to thank Eva Pharma for their nice webinar today, and thank my professor, Dr. Shem Farou, and Dr. Shem Ali and Hubrin Malam for their nice co-hosting for this event. Thank you so much.
Thank you very much, Dr. Ihab. Once again, I would like to thank Eva Pharm and Dr. Muhammad Hassan, Dr. Andrew, Dr. Adil, and all who stayed tuned up to this moment with us. And thank you, and waiting to seeing you once again in more OPSI webinars. Thank you very much. كل سنة وحضرتك طيب. شكرا.
Dr. Shem, we're going to open questions, floor for questions. Anyone have any questions to be answered?
أو كان في questions أحيانا رديت عليها باي شاتنج، يعني مش عارف اذا كان في حاجه جديده ولا لا.
في حد عنده اي سؤال تاني ولا حاجه؟
شكرا جزيلا. شكرا.
Thank you, Dr. Shem. Thank you. Thank you, Dr. Shem. Thank you, Dr.
شكرا جزيلا كلكم. شكرا جزيلا. شكرا يا فارم.
Thank you.
شكرا.
Thank you.